It is very heartwarming to see the community of focal therapy colleagues who are doing so much to improve the field. So you gave me this quite challenging talk, and I really had to think very hard. How do I link what we've done in ProtecT for the last 20 years with all the efforts in focal therapy? So I'll do my best, but I bring you greetings from Oxford and from colleagues there. These are my conflicts of interest. And I just wanted, at a glance, to look at the paradigm changes in prostate cancer over the past century, and they are quite remarkable. So in the 19th century, microscopy appeared, and most cases of prostate cancer were increasingly described in the literature, but small numbers. Early 20th century, all men with prostate cancer presented with advanced disease and died, and Hodges discovered the androgen dependence. Mid-20th century, most men with prostate cancer presented with advanced disease and died. Radiation and surgery started to be used. Late 20th century saw quite a lot of exciting developments. PSA was discovered, transrectal ultrasound. Radical prostatectomy was refined into a reproducible procedure with good outcomes. Multimodality treatments started to emerge and given in advanced disease, neoadjuvant and ADT, radiotherapy, brachytherapy started to emerge. A new technology emerged for partial ablation of the prostate. The early 21st century, chemotherapy, second-line androgen suppression made a huge difference. Imaging totally transformed the diagnostic pathway, and it has transformed focal therapy as well, there's no question about it. And prostate biopsy approaches also have changed and are the subject of evaluation. Now, the PSA, refining radical prostatectomy and being able to do transrectal biopsy created a new global problem. And the problem is on the left, you can see these are recent WHO figures. The blue bars are the incidence of prostate cancer, and the little red bars are mortality from cancer. And you can see that as you move away towards the west and the northern part of the hemisphere, the discrepancy between the blue bars and the red bars are quite remarkable. And it's created three new terminologies in prostate cancer. One is overdetection, the other is overtreatment and undertreatment, because we still see patients who die of prostate cancer. And I'm just going to try and elaborate on these. But I want to go back to basics. What is it that the patient wants? What does a 50-year-old man who's worried about prostate cancer want to know when he comes to the clinic and he talks to his physician? Well, he wants to know whether he needs to be tested for prostate cancer and what is the best test to do this and how accurate is it going to be. He wants to know if he has prostate cancer, and he wants to have sufficient information about the cancer itself. He wants to know whether the cancer is going to kill him. And he also wants to know what the best treatment is that we can offer him to prevent him from dying from the cancer or from suffering from the disease itself. He wants to know the advantages and disadvantages of the treatment that we're offering, including more and more the level of our expertise. And most importantly, every patient is going to be different, because every patient will have different priorities and will want to weigh what is the balance of risk. How is this helping me, and what is the trade-off between the impact of the treatment on the cancer and the quality of life that is going to be affected by it. So the early 90s were plagued with lack of evidence. There was no evidence that PSA testing and treatment of localized disease improved survival or quality of life. There was an increasing burden to healthcare providers and society. There were uncertainties for patients over what was the best treatment. Is it surgery? Is it radiotherapy? And treatment options had never been compared previously head-to-head in an RCT, randomized controlled trial design. And the safety and effectiveness of focal therapy were not evident. We're talking about early 90s. They were just emerging. And To the extent that people will remember Don Coffey, who was a giant of prostate cancer research at Hopkins, and I remember I was junior faculty in Newcastle at the time, and I attended a meeting in the US full of urologists, and Don Coffey appeared. It was at the time where everybody was getting a radical prostatectomy, everybody. Gleason 6, Gleason 7, Gleason, you name it. And he said, you guys are not treating prostate cancer, you are harvesting prostates. And he was so right. And in order to face with the issue that there was massive overdetection and maybe all these Gleason 6s didn't really deserve to be treated, then a famous urologist started to create active surveillance. And I tell you, active surveillance is not the answer for overdetection. The real answer to avoid overdetection is to target screen and to be able to identify the patient who has lethal disease, who has disease that deserves to be treated at baseline or even before the diagnosis. Once you diagnose a patient with prostate cancer, you give them a passport. You give them a cancer passport, and that cancer passport stays with them for the rest of their life. And it is likely that that passport is going to tip them into receiving treatment, be it radical treatment or focal therapy or other. So randomized trials started of treatment effectiveness, SPCG4, the first one, but it was pre-PSA era. The PIVOT trial also started and was reported, and 3 screening trials. One was the ERSPC, the other was PLCO, and the third one in the UK, the most recent, was CAP. And there were problems with all of these trials. There were pioneer trials, and they delivered a huge amount of work. But based on the information that these trials have delivered, the US Task Force in 2011-2012 put a recommendation out, which was a D recommendation, and that is that no man should be tested for PSA. So what was missing from these trials? Well, SPCG4 and PIVOT were non-screen detected cases. SPCG4 and PIVOT had, they're no longer contemporary examples of what we see in the clinic today. Observation was watchful waiting, not active surveillance. Radiotherapy was not evaluated in any of these trials. There were high competing morbidities. In PIVOT in particular, randomization was low. Genomic diversity was suspected, but stayed unknown, and there was very poor risk stratification, as I will show you within ProtecT in a second. Most importantly, the trade-off was insufficiently considered in all of these trials between the oncological outcomes and patient-reported outcomes. Screening was found to be effective, but with an unacceptable rate of overdetection. And of course, PLCO was not able to deliver any meaningful outcomes because of the heavy contamination. The inspiration for ProtecT came from this man. This was Jeff Chisholm, who you may have known. He was a professor of surgery in Edinburgh and a urologist. And he wrote in the British Journal of Urology in 1993 an editorial about PSA testing. And he says, it must be clear that this debate cannot be resolved because there has never been an appropriate trial either of screening or radical surgery or no immediate treatment. Indeed, until randomized trials are performed, we will not know if early detection with or without radical treatment improves cancer-specific survival. And of course, he was absolutely right. So this inspired us to develop the ProtecT study design, and at the time, nobody believed that you could diagnose a man with early prostate cancer and randomize them to a non-intervention arm. So the funders asked us to do a feasibility, which we do. It was led by my colleague Jenny Donovan, and there were 3 questions that we asked. The first one, is it possible to do community-based PSA testing? The second one was, would men accept randomization to one of 3 arms? And the third one is, could nurses recruit men as effectively as urologists? And we achieved, we were able to answer all 3 questions in a positive way. And then the main trial started in 2001, and recruitment finished at the end of 2008. And this was a classic simple, major PSA testing program followed by a 3-arm randomized trial of treatment effectiveness in localized prostate cancer. The treatment options were active monitoring versus radical prostatectomy, mostly open, and radiotherapy. Primary endpoint was disease-specific survival at a median of 10 years, and then we had many secondary endpoints, including all-cause mortality, progression, metastasis. Most importantly, we had patient-reported outcomes, which gave us the opportunity to build information to help patients with the trade-off that I was talking about earlier. So ProtecT was born in 1999. We tested over 82,000 men, diagnosed 3,000 cancers, and of those who had localized disease, 1,643 were randomly allocated to monitoring, which is a form of surveillance, radical prostatectomy, or radiotherapy. The study options were active monitoring, which is a form of surveillance. Men were followed up with PSA testing. We didn't have any MRI at the time. And reevaluation. They were offered radical treatment if the disease appeared to progress. And I insist on the word appeared because we don't have firm confirmation that the disease had actually progressed. The purpose was to avoid unnecessary treatment whilst keeping the patient in a window of curability if treatment became necessary. So there were two steps. One was a trigger for further investigations, and the trigger was rises of PSA, 50% over 12 months, any symptoms, changes in DRE or patient anxiety. The investigations were imaging and repeat biopsies, and the change of management, if there was a suggestion of disease progression, was for the patient to receive radical treatments. Surgery was open and radiotherapy was neoadjuvant with conformal therapy 74 gray. So at 10-year median follow-up, we published the clinical outcomes and the patient-reported outcomes, and much to my dismay, I was hoping we would show superiority of radical treatments, if not superiority of surgery over the other approaches, and it didn't. And this is what we showed at 10 years. There was a very, very low mortality, 1% disease-specific, 10% all-cause mortality. But where there was a difference is in the reduction of metastasis and disease progression by 50%, i.e. from 10%, around 10% for patients on active surveillance to 5% for men who received treatment within 12 months of the diagnosis. And these were the patient-reported outcomes you're familiar with all the information about the urinary leakage and sexual dysfunction, which was worse with surgery, less so with radiotherapy and active surveillance. And this was 6-year full follow-up, and we've published recently the 12-year follow-up. Taking this information and the new information on ER-SPC and CAP, the US Task Force revised its recommendation and now said it's a C recommendation for men up to the age of 70, where it's shared decision-making between the patient and the physician, understanding the consequences of PSA testing, and the D recommendation remained for men of 70 and older. Now, there's an interesting phenomenon that's happened in that between these two US Task Force decisions, everybody anticipated, which was true, that because PSA testing was reduced, the presentation of men with advanced disease, metastatic disease, would increase. And indeed it did. But at the same time, everybody thought that mortality would also increase. And it didn't. And that was a very puzzling epidemiological phenomenon here. And maybe ProtecT and some hypotheses, which I'm going to show you, could help to understand. So this was the 15-year outcomes, and again, a huge amount of work on the patient-reported outcomes with Jenny leading on that. The first thing that we did at 15 years is revise or do a more in-depth patient stratification. And initially, there was a misconception that the whole ProtecT cohort was very low risk, and therefore there's no surprise that there are no differences in mortality. But when we did, using all the instruments that we had available, we did an in-depth risk stratification. We found that, in fact, more than a third of men had at least intermediate risk disease, and 2% had high risk disease. Sorry. Can I go back? Yeah. So this is the prostate cancer-specific survival. I personally was convinced that if at 10 years there was a difference in metastasis, by 15 years we would see a difference in mortality. And we didn't see a difference. So the three arms are really overlapping, 97% survival and 3% mortality irrespective of treatment allocation. The metastasis remained at 10% risk of metastasis at an average of 15 years, 5% on active surveillance, 5% with radical treatment. So what was new at 15 years? The risk of death from clinically localized disease was very low, 3%, or survival of 96, 97%. So that was a really good news story for the patients. Men with metastasis do not necessarily die of prostate cancer. And I'm going to pursue that reflection and that thought with you in a minute because it's really quite important. Men who die of prostate cancer have lethality features yet to be identifiable and are not easily impacted no matter what you throw at them. And Samir showed a beautiful example, somebody who's received good focal therapy followed by good radical treatment, and he's still got bad disease. So we see these men, there are only a few of them, we see them, no matter what you do to them, they end up dying of the disease. Our current risk stratification methods are really poor. And new tools are needed, and I know there's huge efforts on AI and others. The indications for active monitoring surveillance can now be expanded safely, and NICE in the UK has expanded that in 2019, and I'm sure they're going to pick it up in the next iteration, where Gleason Grade Group 2 now, NICE is saying we can discuss active surveillance with these patients because they tend to behave more like Gleason 6s. The long survival, ProtecT is not a trial of screening, but all the data and the information that we've got with the long survival of screen-detected prostate cancer with or without treatment, with or without metastasis, does not really support population testing for early detection. And most importantly, treatment decisions need to balance trade-offs between the reduction of metastasis, long-term hormones, local progression with radical treatments against the short, medium, and long-term impacts on sexual, urinary, and bowel function that we got from our patient-reported outcomes. These are some interesting observations. These are 13 men who died, so we had 45 deaths in the whole of the cohort from prostate cancer, disease-specific, and we had about 104 patients who developed metastases. These are the 13 men who received radical prostatectomy amongst multimodality approaches and other treatments, and they all died. And if you look at the color coding here, what you can see is that the red color coding are men who were stratified as high risk at diagnosis at baseline, and there were only 2 of them. And the yellow are the men who were classified as intermediate risk, and all the others were low-risk disease. Now, you may say, this is because you didn't have MRI, this is because your biopsies were not targeted, etc. The fact of the matter is that all these men, with all the treatment modalities that were offered, still died of prostate cancer. This is another interesting observation. So these are the number of men who were allocated to the 3 arms. These are the number of men who were alive with metastasis at an average of 10 years, and these are the men who died of prostate cancer at 15 years. And what you can see is that in the men who had active surveillance, who were allocated to active surveillance, only 14% of them died at 15 years. The ones who had received surgery, 25% of them died, and the one who received radiotherapy, 70% died. Now, the numbers are small. You can jump to conclusions too quickly, but it is very interesting to see that the men who were on active surveillance are the fewer who died. Why? Who knows? Maybe it's because they were on active surveillance and we were following them up very thoroughly, and we jumped into the window of curability and we managed to cure them. And the others, maybe it's because they really had these lethal features which killed them at the end. So traditionally, we always talk about indolent prostate cancer, low risk and high risk prostate cancer. And in fact, I don't think that prostate cancer is as simple as that, and it's not just 2 phenotypes. I think it's probably at least 3 phenotypes. One of them is non-metastatic, non-lethal disease. So these, even if they progress locally, they do not metastasize and they do not become harmful. Then you have a phenotype with metastatic disease that develops, but they don't die. Why? Partly because of the treatments that we offer, which are very advanced now, but there is something missing in these patients which doesn't kill them. And then you have a small number of men who have lethality features, and no matter what you do to these men, they die. Our Achilles heel in prostate cancer is genomic diversity. We don't talk enough about it. We don't do enough about it. This paper is now 10 years old. Michael Hafner from Hopkins, who took a man who was in his 40s and followed up, and he died 17 years later. He had all the possible treatments, and every time he progressed, some of his tissue was biopsied. And then they did sequencing, trying to trace the clonality of the cells which killed the patient. And surprise, surprise, they found that the least aggressive clone of cells in the primary tumor was the clone that went to the metastasis and killed the patient. Now, that threw quite a lot of anxiety among scientists, amongst clinicians, but people said, well, this is one case. It probably is an accident. But there were so many other papers that came after that. This is one from Colin Cooper's group, trying to analyze the genetic phylogeny of multifocal prostate cancer. And the bottom line is that there were mutations which were found in these cases at high levels in what looked like benign prostates, and yet these mutations were distant from the cancer but shared by it. And some of our recent work looking at transcriptomics this time, not whole genome sequencing, looking at the spatial composition as far as this transcriptome is concerned in patients with a lot of useful material. And what we found is that there are events of evolution in these cancers, and the power of the molecular and spatial continuum which really pose a challenge to the conception of focal therapy, because we do not know enough about where is the tissue that is likely to have these lethality feature which kills the patient. When a plane crashes, we all talk about the black box. And the black box is the flight recorder. And you know, I only found out last week that the black box is never black. I could not find a black box which looked black. They all look red. It's extraordinary. I even phoned a friend of mine who's a pilot, and he said, no, they're not black, they are red. But that's what they are. And every man who dies of prostate cancer has in his tissue and in his blood a black box. And that black box has the information about why he crashed, why he died. And this is just an example of trying to find out. So this is part of our work with our pathology colleagues, looking at the PAGE project, looking at patterns of recognition in biopsy material, because this is where you want to find the lethality features, not after the prostate is removed. It's too late. You can't put it back in. And this is going to show patterns of recognition in benign or in malignant disease, which is going to give us information about lethality. You can only do this if you have cohorts of men with very long-term follow-up and what we call A-star patients who actually died of prostate cancer. Unfortunately, we have that in our ProtecT cohort. So what are the challenges, considering all this information, what are the challenges for partial ablation? Well, one we talked about is tumor multifocality and heterogeneity, genomic diversity in particular. Imaging, and you're addressing this beautifully, targeting, monitoring, retreatment, all this was really described in a most elegant way in these last 2 days, optimal salvage treatments. But although there is an increase in number of RCTs, there is still a lack of high-level evidence of treatment effectiveness compared to whole gland treatments, unfortunately. So there's been an updated systematic review, one of them very recently I came across, and this was quite remarkable. So what they found is 72 studies analyzable with 5,000 patients reported. Out of these 72 studies, only 2 were randomized. One was the VTP trial against active surveillance, which really handled low-risk disease, and the other was our own part feasibility study comparing in intermediate-risk disease HIFU against radical prostatectomy. And the conclusion was that although there is ample evidence of safety and good quality functional outcomes, there is still insufficient data and evidence about comparative treatment effectiveness from an oncological point of view. EAU guidelines 2022-2023 now recommend the use of focal therapy in the context of clinical trials or registries, and this was picked up by NICE also. This is our own work, the part feasibility study, which we published in 2018, comparing HIFU with radical prostatectomy, and we managed to recruit the patients successfully. Then the full part trial now has just opened. Richard Bryant, who's here, has taken over as chief investigator and is running it. The trial is open. He's started to recruit patients. More sites are going to be open. And what the ambition we have is to convert this trial into a global RCT rather than just one, which is confined to the UK. I've explained to you. So just one point about treatment failure in the PART trial. It's about persistent intermediate grade cancer in initially treated area. After repeat ablation, 2 treatments are allowed. Repeat ablation, which requires whole gland treatment, which is more than 75% of the gland. Positive biopsies with high-grade prostate cancer at any time, and extraprostatic disease progression defined by imaging and other investigations. So to conclude, what about focal therapy in the ProtecT era? These are some of my take-home messages. The most important one, I think, is that we must not convert focal therapy into the placebo effect for patients who can be managed safely by active surveillance. And they can be, and not just for Gleason 6. We must have the courage to evaluate the treatment effectiveness of focal therapy in higher risk disease. There's a phenomenal shift in the last 30 years, going from treating all Gleason 6s and 7s by surgery, the higher risk ones by radiotherapy. Now, we have lost the Gleason 6 and early 7s, the favorable 7s, and the interventions are shifting more towards the right. So should focal therapy as well. It should move more to the right. We must find these black boxes. Without finding them, we're still going to be treating patients with blind eyes. I've had one talk which mentioned the impact on the immune system. We must investigate the potential abscopal effect of focal therapy. You're using amazing energy deliveries, technologies. The attraction of the abscopal hypothesis is there. Treating physically a tumor could generate a T-cell immune response, which then treats the rest of the tumor elsewhere, even if they are not localized. And that needs investigating. We must not be driven by technology, but we must drive technology with our industry partners to respond to the unmet needs of our patients. We all have heroes. This is a Spanish poet, Antonio Machado, and I like his sentence here, his quote. There is no path in all of this, as you can see, but we can have a path, and the path is made by walking. And I'll finish with the sun setting on the Oxford spires, dreaming spires. Thank you very much for listening.
We cannot deny you the opportunity to ask any questions you have of Professor Hamdy. So while we are running behind, we're going to take some time to to see if there are any questions from our audience. Thank you.
Freddie, that was fantastic. I learned a lot, but I'll be thinking about what you said for a lot of days to fully process it. But, you know, I was very interested in the risk mortality segregation between the arms of ProtecT. I have trouble figuring out what focal therapy will really end up being. It's hard to believe that it will be a more efficacious intervention. But I wonder if the real benefit, obviously, will be the mitigation of the bystander effects of radical therapy. So do you see focal therapy evolving as a way of, it seems to me in your surveillance cohort, the worst thing that could happen to them was radical therapy. They weren't dying of prostate cancer. So is focal therapy a way we can take low-risk cohorts and remove that? Because obviously the risk of lethality is genomic or genetic, but that's still time dependent. It's not from the start. So is focal therapy a way you can take somebody low risk and prevent them from ever receiving radical therapy when they weren't really destined to die of the disease? Is that a good outcome?
It is possible, but I'll refer to your first comment in the first place. And the first comment was mitigation of the side effects of the radical treatment. And that is absolutely correct, because I believe that when there are primary endpoints in focal therapy trials, RCTs in particular, they should be co-primary endpoints, not just about the oncological outcomes or what happens at your biopsy at 1 year or 2 years. They should be equal weighting between the patient-reported outcomes and the quality of life and the oncological outcomes. Now, you said yourself that the best oncological outcomes are disease-specific survival and all-cause mortality. And it takes 20 years to be able to get there. So if we use these co-primary endpoints in the RCTs that you are all starting to do or are doing, you will be able to give the patients the information about the trade-off. So if I have focal therapy, I may delay radical treatment or not have radical treatment at all by 5-10 years. If you're a 50-year-old man or a 55-year-old man and your sexual function is important and you don't want to leak urine, what is wrong about having a treatment which is going to delay as long as possible your radical treatment if you need it, but without impacting on your survival? And I think this is a great niche for focal therapy, which needs to be incorporated in how we make conclusions and how we drive the conclusions of a clinical trial in focal. I think it's really important. So I completely agree that this should be the direction of travel for focal.
Great talk, Professor Hamdy, as always. As you presented, 10-year mortality was 1%. But assumed hypothesis was 10% mortality in 10 years. That was for the ProtecT trial.
Yes.
So the mortality was only 1% in 10 years.
Yes.
So will this change if you follow these patients for longer term? That is number one. Second, in the patient who are in active monitoring,
yes,
almost 2/3 patient, they chose the treatment. So 2/3 of patient
yes,
trial, they move on to the treatment.
Sure.
So we are talking only 1/3 of patient who stayed on the active surveillance. So that is my question number 2. Now question number 3, the people who are in active monitoring, they have the more progression, means they develop more progression in comparison to the people who underwent the treatment. Similarly, they have almost, I think, 9.9% metastasis and 25.9% progression in the disease. So these are the 3 questions when I was reading your paper. And
so I'm going, please stay, because I probably will, I'll respond to one, I'll forget the other 2. So I'll just respond first about the 1% mortality and the patients who move from active surveillance to radical treatment.
Correct.
So we know that at 3 years, 25% switch over. At 5 years, it's about 40%, and then it's 50% at 10 years, and it's 61% exactly at 15 years. And somebody was asking me this question earlier. It is very difficult, because I showed you what the criteria were. And we only had PSA. We didn't have PSMA PET. We didn't have MRI. So if the PSA went up a little bit, that generated anxiety with the patient. It also generated anxiety with the physician. And all you needed is a bit of anxiety from one, a bit of anxiety from the other. Then the family there saying, actually, we're not happy because we think that disease is getting worse. We did not have a lot of objective evidence that the patient was actually really progressing. Even if you look at the repeat biopsies, so at an average of 7 years, we looked at who was getting repeat biopsies, and it was only 11% of men. But even in those, if you have without, and I'm talking about pre-MRI era, if you have biopsies which show, repeat biopsies, which show a Gleason grade group 3 instead of a Gleason grade group 1 or 2, do we really know that this is progression after 3 years? I don't believe it is. I think it's probably undersampling of the original baseline biopsies. So we are trying to prepare a paper together on the patients who went from active surveillance to treatment, and it's very difficult to ascertain the real reasons behind the switch from active surveillance to. And that's why I go back to my initial point. What damages patients? It's not so much the treatment that you give them, it's the diagnosis of prostate cancer. If they have non-lethal prostate cancer, it's much better off them not knowing about it at all. So that was maybe 2 points. Right. What was the third point? Sorry.
No, the third point, even the people who stayed on the active monitoring, they
Yes.
develop a 9.9% metastatic disease, and 25.9% they develop progression of the disease.
Yes.
So the question, even on being an active monitoring, so this is a great space where focal therapy can play a great role for in these patients.
Of course. It's finding those niches.
And
exactly.
also the little bit, from UK, every year almost 30 or 40% patients, they die of metastatic prostate cancer. Whereas in your trial, in 17 years, only 55 patients died.
Right.
So why there is a big difference in?
The statistics are different now for the UK. And the number of men presenting with metastatic disease is very, very low, and the men who develop metastatic disease is going down also. Ours are very low, probably because we used a 50 to 69, and we triaged all the men before we invited them to come forward for PSA testing. So they were truly PSA screen-detected patients, whilst the rest of the UK population, there is no systematic screening. So these are the differences.
Thank you very much, sir. Thank you.
Thank you very much, Dr. Hamdy, Professor Hamdy. The slide that still has me perplexed is the discordance between metastasis and survival stratified by treatment type initially. So my question to you is burden of two things. One, you see some of the sharpest minds in medical oncology delay androgen deprivation in the salvage setting as long as they can, especially in the era of PSMA PET, because that creates the stress for tumor plasticity and differentiation and lethality. So in the patients that I assume started on radiation therapy, their probable subsequent metastasis diagnosis may have been post some level of androgen deprivation ahead of time, whereas with active surveillance and surgery, those patients probably had either a delayed access to the androgen deprivation or their metastasis was discovered at a lymph node dissection level as opposed to an imaging. Is there any work being done now to sort of delineate burden of androgen deprivation in those three arms? Or if the diagnosis of metastasis was different, whereas radiation is a bone metastasis, whereas the other group may have been on surgical dissection?
So we actually published the same in that with active surveillance, there is a significant increase in men receiving androgen deprivation. And it's more or less the same. It's also about 10 to 20% versus 5 to 10%. So that's the difference in that there is no question that radical treatments, whole gland treatment, within the first 12 months from diagnosis in ProtecT reduced the number of men receiving androgen deprivation compared to active surveillance. And again, that is largely driven by, exactly as you said, what are the thresholds at which point the medical oncologist is going to be sufficiently nervous to say, we now need to start androgen deprivation. So that I hope that answered the question. Please.
Professor, thank you very much. I'm Ali Castrine from Jacksonville, Florida, and I get a great opportunity to work with my dad, who's a urologist who trained and grew up in the era where people showed up with a metastatic disease and passed away from prostate cancer.
Sorry. Yeah.
And, you know, one thing he always says is the more we learn, the more we discover how little we actually know, and prostate cancer is a perfect example of that. What are your thoughts on the controversy and the movement to not call Gleason 6 grade group 1 cancer actually cancer? And from the pathologist's point of view, it looks like cancer. It meets all the criteria for cancer, but it might not biologically behave that way. However, we don't have the black box. We don't know yet well enough or with strong enough confidence which of those cancers is going to be the one that changes.
You know, my personal thoughts is that it would be very imprudent and unsafe to stop calling Gleason 6 cancer, because it really has some of the hallmarks anyway of cancer. And we had a very interesting debate recently in the BJUI where there were very, very strong views about should it be called cancer or not. And it reminds me a little bit of how, you know, and why Laurie Klotz started active surveillance. Active surveillance was started as a reaction to the Gleason 6 and how they behave. And I think this is also another reaction towards the Gleason 6. We're not going to do active surveillance, but we're not going to call it cancer. And I think it's wrong. I think we need the black boxes, really.
Thank you very much.
Thank you.
I'm delighted and honoured to be in your presence.
Thank you.
I just wanted to say or bring a comment, and it's really after Dr. Tanesia's comment as well. We started doing focal therapy for a 75-year-old guy who's got a MRI positive lesion, a 3+4, favourable 3+4, which we're just not quite comfortable with actually treating with active surveillance. It seems to me now that we're moving away from that. And what we're saying now is that, well, heck, the future of this guy is genomic. And so the local therapy shouldn't hurt the guy. And so the philosophy of who we should be treating, and I think what you're saying is being brave here, is to treat a high-grade cancer. Don't hurt the person with incontinence or impotence or these type of things, and deal with the genomics. I mean, we recently published in Nature the difference between African cohort with a 20-year follow-up versus an Australian high-grade cohort, and the genomics are totally different, and the death rate's totally different. And that was the first time that's been discovered. But would it be fair to say that we're moving away from well, there's two groups. There's the group of the high-grade one we don't want to hurt, and let's work out the genomics, and then there's the low-grade one we don't want to over-treat.
You're absolutely right. That's the direction of travel. And I'll just give you one example, one scenario, why you are so absolutely right. Let's take the part trial that we're running, okay? These are men who are fit and they have unilateral cancer. And they will be randomized between a radical treatment. We all know the side effect profiles of the radical treatment. And the other group will be receiving a form of partial ablation, be it HIFU or irreversible electroporation. Take two men. They're both 50. One receives the radical treatment. They get problems with continence, sexual function, and they're going to carry this throughout the rest of their life, and they may need secondary treatments later on, but they may not have the lethality features and they may not die of prostate cancer. Take the same 50-year-old on the other side who receives electroporation, and he receives a first treatment and it works and he's fine. 5 years later, he receives a second treatment and it's fine. Another 5 years, and now it's time to do whole gland treatment. By that time, he's 70. You have spared him 20 years of side effects from the radical treatment. You haven't harmed his mortality. And who's going to be better off out of these two? Do you see this as a live example of what we are trying to show? But in order to demonstrate this, we have to do the randomized trials. We have to, because there is no regulatory agency which will accept data unless they emerge from high-level evidence of RCTs. You're all doing amazing work with single cohorts, and it's great because you're producing data. The final blow, which will make FDA, which will make NICE, which will make the European agencies change their mind, is hardcore evidence from large RCTs. So it's a plea for all of you either to design your own or to join force together to get these really, really important data. I think we've run out of questions.